Hi, my name is Gail Hausman. I'm a nurse with ALS United Mid-Atlantic, and I'm here to talk about what is ALS. So what is ALS? ALS is a progressive neuromuscular disorder that involves the wasting and eventual death of the motor neurons. Motor neurons are also the motor nerves. The motor nerve eventually shrinks and dies, and that leads to the wasting of the voluntary muscles that the nerve is innervating or connected to. So the motor nerves innervate the voluntary muscles. They get the voluntary muscle to do the work that it's supposed to do. So eventually the voluntary muscles that are affected by ALS are the arms, hands, legs, feet, chest, abdomen, back, neck, throat, mouth, tongue, the diaphragm, and other muscles used for inspiration. They're all the voluntary muscles. ALS does not affect sensory nerves or involuntary muscles. About 50% of people with ALS have some cognitive impairment. The impairment is usually mild, occasionally severe, and I'll go into that later. So the regions, as far as the body goes, they divide it into 4 regions, and ALS usually starts in one region. Oftentimes it's either the lumbosacral area, which are your lower extremities or your legs, or the cervical area, which would be the arms, hands, and diaphragm. Occasionally it starts in the bulbar muscles, which are the muscles we use for chewing, swallowing, and speaking. And it can also involve the thoracic area, which is the chest and back. So it usually starts in one segment and then goes to another. There's 2 motor neuron or motor nerve groups involved with ALS. So there's 2 groups that are impaired. The upper motor neurons, which are in the brain and spinal cord, and then the lower motor neurons. The lower motor neuron gets the signal from the upper motor neuron, and it sends the signal to the muscle impaired. Okay? It's not so much upper and lower parts of the body. It's the brain and spinal cord would be the upper motor neurons, and then the lower motor neurons are the nerves that shoot out and go to the various muscles. So there's 3 other illnesses that are similar to ALS, but they're a little varied. So there's something called PLS, primary lateral sclerosis, and that involves the upper motor neurons only. Eventually, the lower motor neurons may also become impaired. There's progressive muscular atrophy, or PMA, and this is the flip. It's the lower motor neurons that are involved, not the upper. And again, like PLS, the upper motor neurons can also become impaired at some point. And then there's something called progressive bulbar palsy, PBP. And that's where you have both upper and lower motor neuron damage in the bulbar muscles. The bulbar muscles are chewing, speaking, swallowing muscles. Usually, eventually, there's impairment to other parts of the body. So classic ALS is upper and lower motor neuron impairment. PMA is lower motor neuron only. PLS is upper motor neuron only. And PBP is both motor neuron sets, but in the bulbar muscles only. So some people have more trouble, even if they have ALS, they have more trouble or more symptoms of upper motor neuron problems. Other people have the opposite. So for the people that have more upper motor neuron problems, they're going to have, both will have weakness, okay? But with upper motor, you have more spasticity. You have like a tight pulling feeling in your muscles. Where in lower motor neuron, what you're going to have is cramping, which are kind of like Charlie horses. With upper motor neuron symptoms, you're going to have poor fine motor coordination, so like picking up things or doing buttons. The neurologist is going to see brisk reflexes on exam. And sometimes people with upper motor neuron symptoms have something called pseudobulbar affect. And that's a symptom that involves uncontrollable laughing or crying. Something will set you off and you kind of have sort of a heightened response to it. With lower motor neuron symptoms, you're going to see fasciculations, which are uncontrollable muscle twitching. The neurologist is going to see decreased reflexes on exam, and you're going to see atrophied or wasted muscles. Typically that's seen in like the hands and some of the facial muscles. So who gets ALS? So ALS occurs all over the world. It's roughly 1 to 2 per 100,000 people, every culture. In the military, statistics are that it's between 2 to 4 people per 100,000 people. So that's twice the average, and that includes any branch of service, any time period, and any type of service. It's not just folks that have seen active combat, it's also folks that have been stateside, and they don't know why. It's more common in men until the age of 65, and then it equals out. Most people with ALS get diagnosed between the ages of 40 to 70, but unfortunately we've seen some later teens get diagnosed and also some folks in their 90s. The average lifespan after diagnosis is roughly 2 to 5 years. Although, and I have this in bold on my slide, progression, severity, and symptoms of ALS are unpredictable and vary from person to person. There's 2 forms of ALS. There's sporadic, which is the most common form, and that's 90 to 95% of the people that have this illness have the sporadic form. And basically that just means that there's no family history of ALS. Then there's the familial, which is roughly 5 to 10% of people that have ALS, in that it runs in families. If you're a person with ALS, your offspring have about a 50% chance of getting the gene. They've been able to identify a whole bunch of genetic mutations, roughly accounting for about 70% of the familial cases. So meaning there's still about 30% of the genes that they haven't been able to find, but they know that there's a genetic component. So what causes ALS? There are risk factors. So we've already said being in the military and having a family history. The older you get, the more, the greater the risk. And also if you have frontotemporal degeneration, and I'm going to go into that shortly. I have causes with a question mark because they still really don't know what causes ALS. They've been looking for years and years and years, decades, and they haven't been able to find. What I read is that for both the familial and the sporadic is that there's a complex interaction between multiple genetic and environmental factors and aging. Again, with the familial, they've been able to identify about 70% of the genes. The first gene that they identified was called the SOD1 gene. And the most common genetic cause is the C9orf gene. They're looking at all kinds of possible factors, genes, environmental toxins, issues related to structures within the motor nerve and outside of the motor nerve. They believe that excess glutamate sitting outside the motor nerve can damage the motor nerve. Oxidants, possibly viruses, and possibly inflammation. There's been other possible factors that have been featured in the news: smoking, brain trauma, and service in the military. There was a large study. They looked at ex-football players, and there was a higher than average rate of ALS amongst ex-football players. So they believe that had something to do with trauma. But there's no definitive cause. Symptoms of ALS, early symptoms: changes in fine motor coordination, so writing, picking up things, turning the key on your, turning the ignition on your car. Cramping is an early sign, especially in the lower extremities. Fasciculations or muscle twitching. Some people report a foot drop, where they're walking along and it feels like one of their feet is sort of dragging. Very often, change in voice quality or slurred speech. And primarily that is noticed by the loved ones. They'll say, "Oh, it sounds like your voice is a little different." Orthopnea, which is trouble lying flat because of shortness of breath. So a person might be able to sleep sitting up, but they feel breathless laying down. I have a little asterisk there because these symptoms may occur with other illnesses also. So ongoing symptoms of ALS: there's weakness, muscle weakness, fatigue. If you are lacking muscles in your legs, walking is gonna tire you out more so than usual. Problems with mobility and getting your ADLs done. ADLs are activities of daily living, and that would be like, showering, shaving, brushing your teeth, etc. Pain. So some people with ALS have significant pain. Others report very little to no pain, but some people do have severe pain, spasms, cramps, and then pain related to not being able to get up and move. Difficulties with speech, difficulties with chewing and swallowing, difficulties clearing secretions, because if you have like saliva that's kind of dripping in your mouth, we just swallow it. But if you don't have good muscles, which would be the bulbar muscles to swallow it, then it might come out, which is drooling. And then mucus, when you have mucus in your throat, we all clear it. But if your throat muscles are impacted, then sometimes it's hard to clear that. Shortness of breath, orthopnea, so again, trouble laying flat, the pseudobulbar affect, and maybe depressed, anxious, and or having trouble sleeping. So ALS usually does not affect the bowel and bladder because they're covered by involuntary muscle. The same with internal organs. It doesn't usually affect sexual functioning because people still feel. So they still feel pain and they still feel pleasure. Again, it doesn't affect the sensory nerves. Okay, and it doesn't affect any of our senses. Feeling is one of them. And seeing, tasting, smelling, and hearing are not affected. So I've spoken briefly about cognitive impairment in ALS. When I first started with ALS United Mid-Atlantic, I was told that there was never any cognitive impairment with this illness. And then going further, I was told that yes, about 50% of people with ALS have some cognitive impairment. So it's roughly 40 to 50% have some impairment. It's usually mild, but it can be severe, and that's called frontotemporal degeneration. The impairment can be progressive, and changes are characterized as executive dysfunction, which means trouble with thinking, reasoning, and judging, behavioral or personality changes, and or changes in understanding and utilizing language. So frontotemporal degeneration is sort of the worst of the cognitive impairment, and it doesn't affect. It says 5 to 10% of people have that. Also, it can precede the ALS diagnosis, meaning that people with FTD can have FTD first and then develop the symptoms of ALS. It's more common in people with ALS who are older, less educated, and with bulbar symptoms. There is a shorter survival time for the person with both ALS and FTD. So symptom management is the primary treatment or how we clinicians deal with ALS. Fatigue is a big complaint, and so we talk about energy conservation. Very often people with ALS, if they have a weak limb, they're going to go and get a gym membership and try to exercise that limb, and that actually makes the fatigue worse. What you want to do is actually rest the limb for what's important. So if taking a walk every day is important and you feel more fatigued at night, so take the walk in the morning. We talk about spacing out activities, getting help with things that you can get help with. If you have trouble lifting your arms up to do your hair, get somebody else to do that. For people that are caring for people with ALS, we don't push people with ALS to do more than he or she wants to do, especially if the person is breathless. Okay? We try to help them more. Mobility, primarily we focus on safety. We talk about range of motion and stretching, especially the shoulders if your arms are impaired and the shoulder muscles. Stretching you hold for 20 to 30 seconds and you perform 3 to 5 repetitions daily.
It was an ant. And I didn't want the ant to go over here. I thought it would distract you.
I thought you were giving me, okay.
I thought it would distract you. Instead I ended up distracting you.
Okay, so range of motion and stretching are not a skilled service. It's somebody, anybody can be taught how to do range of motion, which is basically just moving the joints the way that they're meant to be moved in order to prevent contractures. You cannot increase muscle strength to affected muscles, the muscles that are weak, but you can maintain muscle length with stretching. So that's just something that can be taught to you by the physical or occupational therapist. Exercise is controversial in ALS, so we always recommend talking to a PT or OT who are familiar with ALS. Very common prescribed equipment include simple things like reachers, button hooks, something that helps get your socks on, shower benches, utensils, and then eventually people wind up getting various assistive devices for walking and getting their ADLs done, including splints, orthotics, transfer boards, pivot discs to transfer, wheelchairs. Usually start out with a lightweight travel wheelchair called a companion wheelchair, or you may have a manual wheelchair which has the big wheels in the back, or custom manual wheelchair, scooter. We usually don't recommend scooters unless you get that on your own. We recommend that you use your insurance for the power wheelchair because that chair starts at about $25,000. And insurance companies are only going to cover one wheelchair per 5 years. That's the general norm. So for instance, if you use your insurance to pay for a travel wheelchair, which costs about $100, then you can't get the power wheelchair, which costs about $25,000. So we say do not use your insurance for that, or also a scooter, which is less money. So for pain, you want to find out what kind of pain it is. You want to talk about stretching, which I've already talked about, position changes, using cushions, mindfulness. Some people have found mindfulness to be of of help in dealing with pain. Yoga, if you're able to do certain stretches, and when you do get a power wheelchair, it should have tilt so that you can get off your bottom. And I also forgot to mention meditation, because some people do find that helpful if they do it on a regular basis. Medications you would use like antispasmodics for spasms. You would use Neurontin basically, or something like that, for cramps. And some people are using medical marijuana, which apparently does help with spasms and other pain. Dysarthria is trouble speaking. So we ask people to say the most important word if they are able to speak a little bit. So instead of a full sentence, say whatever the word is, water. Some folks, towards the end are not able to, verbally speak. So we sometimes say to them, if they're not able to verbally speak or any other way to communicate, we ask yes or no questions. So move your eyes to the right if the answer is yes. Move your eyes to the left if it's no, and keep your eyes straight if it's a maybe. There's all kinds of tools out there. There's simple letter boards, which just have the alphabet or certain words on them. Something called a boogie board for people that are still able to write, that they can write on this board and then erase it. Laser pointers. Phones have all kinds of apps now, and iPads. There's computers that have apps, and then there's something called a Tobii, which is sort of the high-end communication device where people are able to move the mouse on the computer screen using their eyes. So we have a specialist who has been with our organization for many, many, many years, Elisa Brownlee. She's an assistive technologist, very knowledgeable about communication devices. And she can be reached at Elisa at alsmidatlantic.org or 215-631-1877. In addition to contacting Elisa, I recommend that you contact a speech and language pathologist, an SLP, and those folks are at the clinic, at the ALS clinics. So dysphagia, which is trouble chewing and swallowing. So for folks that don't have a feeding tube, we recommend chin tuck, so keeping your chin down, to concentrate on chewing food slowly, no talking while eating, suggest smaller, more frequent meals, including supplements, and avoid foods that are challenging. So for instance, a lot of times people have a hard time with thin liquids, and they have trouble with foods that have two different consistencies, like a vegetable soup. Caregivers should learn how to do the Heimlich maneuver, just in case. And you should consider a PEG, which is a feeding tube, if you're choking, losing weight, and you want to get that done before there's any significant respiratory issues. So breathlessness or orthopnea. An early intervention for this is to keep the head of the bed elevated. Energy conservation. Very often, 90% of people use something called Trilogy or BiPAP especially. BiPAP is a machine that helps the breathing muscles. It's like an assistive device for the diaphragm and the other muscles that we use to take a breath in. We don't use oxygen. Oxygen is contraindicated without it going through the Trilogy or the BiPAP. For some folks, they find relief from either liquid morphine or from Ativan, and that's something that hospice would have or the doctors can order. And some people, for significant breathing issues, will consider invasive mechanical ventilation via tracheostomy. And that would be like the hole in the throat and the tube that's hooked up to a ventilator that does all of the work of the breathing. So, in and out. Some people have trouble with secretions. They have sialorrhea or drooling or excess saliva. So there's different medications for that. And then some folks get Botox injected into their salivary and other glands, which helps dry up the saliva. And then some people use medical marijuana for that. For people that have mucus in their throat or in their lungs, usually a starter medication would be guaifenesin, which helps loosen it. Some people use albuterol via a nebulizer, which is like the misty thing. You wear a mask and it helps to break up some of the mucus. And then a suction machine just for the oral issues. And then a cough assist is more for the mucus in the lungs. And that helps you to stimulate a cough so that you're clearing, loosening up the mucus. Other symptoms, so for the people that have the pseudobulbar affect, which is the uncontrollable laughing or crying, there's a very good drug on the market called Nudexta, and that really helps with that. And then if they're not able to use the Nudexta, SSRIs is a class of antidepressants that can be helpful. Some people have laryngospasms, which are a feeling that your throat is closing up, and that's from a spasm in the throat muscles. So clonazepam is one drug that seems to help with that. It's very common for our folks to be depressed, and you can imagine, especially I guess after listening to this whole in-service, lots of issues to have to deal with this illness. This is a tough one. So this is what we recommend is antidepressants and or psychotherapy. And insomnia, you want to find out what the cause is and treat that. So are you having insomnia because you can't turn and you need somebody to turn you? Are you having it because you're in pain or depressed? So you have to find out what the cause is, or is it a multiple? So treatment of ALS is, again, symptom management, as there's no cure. So there are several drugs that they're using for people with ALS that may modify the progression for a period of time, and that includes riluzole, Radicava, also known as Indaravone, Nudexta. Some people on Nudexta feel that their speech is a little better, and then tofersen for SOD1 mutation only. And they have Nudexta on this list because some folks who have bulbar symptoms have told us over the years that they feel like it helps with speech. But primary treatment is symptom management. Manage the symptoms, focus on the safety and quality of life, and provide support. It's important to establish patient goals, advance directives, living wills, ongoing treatment wishes with the patient, including insertion of a feeding tube and or use of a BiPAP or ventilator. You want to know what the patient goals are throughout their time with this disease because you want to work with the patient. It's also important to establish the care of the patient, who's going to provide the care, the cost of care, and the cost of DME, which is durable medical equipment. Thank you for viewing this presentation. If you have any questions, feel free to reach out to me.